I'm not going to go through your bio. I'm hoping you're going to share some of your background and your bio with us. But we did manage to find out from her last night that she has some Irish roots, so she may share some of that with us now this morning. But I suppose importantly, she was very important to this research for us because she is a fellow of the Robert Wood Johnson Foundation in the States. She has a strong passion for quality and for advanced practice and for nursing. And she's been a wonderful advocate for the work that we're doing. So thank you, Mary Ellen, and we're delighted you're here.
Well, thank you, everyone. A special thank you to Mary and Anne for inviting me. It's a pleasure, and it's wonderful to be here. My grandparents were born in Ireland, so I haven't, I'm moving ahead here. So one of the things that I really have enjoyed, besides the lovely weather that you gave me, which I wasn't expecting, is to hear the brogue again, because my parents are my grandparents are deceased. So thank you very much. It's a pleasure, and I really feel at home here. I'm going to talk about quality in the United States, particularly a just culture, which is a movement in the United States, and I'm going to talk about it from how to develop it broadly, what it means in terms of standardization, care metrics, managing issues, and also give an exemplar of a hospital that does great work with safety, as well as talk about interprofessional education, because if we're going to be equal, we need to start in school. So that will be my talk, and I wanted to show you where Pittsburgh is. So has anybody been to Pittsburgh here? So Pittsburgh is in Pennsylvania near Philadelphia, and I'm originally from Philadelphia, but it's a beautiful city, and I live in the condo right at the point there. So I thought I'd show you. And that's Pittsburgh at night. And it's a city of bridges. Pittsburgh has 446 bridges. The most bridges of anywhere in the world, I believe, in a little city. And there is my university, Duquesne University. So I just thought I'd tell you where I am coming from. I want to offer a special thank you to my Irish colleagues for the opportunity to contribute to a robust suite of nursing and midwifery quality care metrics. And it has been a privilege to provide some insight and hear about the great work that you are doing. So briefly, in my talk, I'm going to describe some initiatives supporting expanded quality improvement. I'm going to explore a just culture model. I'm going to describe formative quality improvement methods, Toyota production system, particularly the hospital Virginia Mason in Seattle that has one of the best safety records in the United States. And I'm going to talk about the impact of interprofessional education on quality improvement. So one of the things when we talk about culture is really strengthening nursing and nursing's voice. And I was privileged to contribute to the Institute of Medicine report for the future of nursing in 2010. And this report has been a wonderful report where a group of experts looked at the evidence amassed over 50 years related to clinical studies on the efficacy of nursing care. And they came up with 4 major recommendations. Nurses should practice to the full extent of their education and training. Nurses should achieve higher levels of education. And the United States, I'll talk about in a minute, we do not have a BSN requirement, sadly, so hats off to you, but we are trying very diligently to improve the education of nurses. Nurses should be full partners with physicians and other healthcare professionals, and I will talk about how we manage that from an educational perspective and how that has improved in the United States. And effective workforce planning and policy requiring better data collection. We need to know what types of health professionals we need. So with the national mandate for quality health care, as you know, nurses are the largest group of professionals caring for patients and have the greatest impact on outcomes and are a vital link between access to care and quality outcomes. And nurses play a vital role, as you're heard this morning from our wonderful speakers on medical errors, increasing patient safety, reducing infection, decreasing fragmentation of services, and providing culturally sensitive, ethical, and compassionate care. Nurses are leading the effort there. So one of the things that we're working on in the United States with the report of the future of nursing is to really improve standardization of practice, which I will speak to you about, and measurement, and also increase the preparation of nurses at the doctoral level. So we have more nurse scientists, more clinical leaders, and more executives that really understand evidence-based practice and research. In our PhD programs, we are looking at more translational research and evaluation research. In our Doctor of Nursing practice programs, we have put more program evaluation, more quality improvement, and more epidemiology in those programs so that we have leaders in both academia and practice who really understand evidence-based practice. And we're looking that this preparation will really strengthen our profession's response to the national focus on improving healthcare through innovation and quality measurement, and be more engaged, and certainly have an increased focus on engagement like you are doing right here in Ireland with practicing nurses at all levels looking at quality. So we are in the same journey as you are. One of the issues that we have in the States that we are trying to grapple with is there was a real separation of academia and practice. We didn't even speak the same language. And I practiced for a long time before I really became a full-time faculty member. I'd even practiced when I was a full-time faculty member. So I'm pretty grounded in practice. And one of the things that I think has been very, very helpful in the States is a number of the major health systems, we've created academic clinical partnerships where people from academia, faculty, and clinicians meet once a month, sometimes more in some institutions, and they talk about new research, new practices, so they're both learning from each other and understanding what's happening. So that's key. Higher levels of engagement, dissemination of pertinent research I think really strengthens regional and national academic and clinical partnerships. And it really advances practice in terms of research and clinicians working together for new interventions and care models. As much as we want faculty with a PhD working at the bedside, sometimes that's not always possible, or we don't have enough for it to happen, but these academic practice or clinical partnerships can really help with communication so that we are teaching relevant information that students will need, and how do we have quality and safety in our curriculum, and I'm going to talk about how I did that. I do want to congratulate you for having a BSN as your entry-level degree in nursing since 2013. Do I have the right date there?
2006.
Oh, it was 6. I looked on the internet. It was at 2013. Okay, well, 2006, that's even...
Students, I was at 2006.
Oh, okay, well, I'll correct that slide. But, so that, as I said, is not a reality in the United States. I wish it was. We have a large community college contingency, which has a lot of political clout, so that has been a problem. And I don't know that it's going to change anywhere soon because we have a terrible nursing shortage in certain areas. However, New York has just passed legislation to have a BSN in 10. So even if a nurse goes to a community college, they must get their bachelor's degree within 10 years to keep their license. So that's a start. I do think the BSN prepared nurse is the knowledge user, and they're able to use and apply knowledge, and they have, in the United States particularly, coursework in evidence-based practice, so that's important. And I see quite a difference, and I'm going to talk about some studies that Linda Aiken did from University of Pennsylvania, which used to be next door to me when I lived in Philadelphia, that really demonstrate that BSN prepared nurses provide better care. So the BSN prepared nurse is really the knowledge discriminator, And they're able to link and discriminate information, and it helps with the development of clinical reasoning. And I think these skills also enhance the BSN's cognitive ability and moral reasoning to ensure quality and safe nursing care. And quite frankly, with the amount of information in nursing and healthcare now, to think that you can be a nurse in 2 years is really difficult and almost impossible. And there are some great differences, and I see it. Of course, I'm biased. I have baccalaureate programs in our university, but I think it is a problem, and I'm going to talk about some things in terms of failure to rescue and other issues where the BSN prepared nurse does far better just by the nature of their education. So a recent study that was just done at University of Pennsylvania, having BSN prepared nurses really helped with patients with Alzheimer's and related dementia. It was Dr. Elizabeth White and her colleagues at Penn. And what she found is she did a retrospective study of Medicare clients. Out of 353,333 patients, 46,000 or 163 had Alzheimer's or related dementia. And what she found is that individuals undergoing surgery who have a coexisting Alzheimer's or related dementia diagnosis are more likely to die within 30 days of admission and die after a complication than those without. But having more nurses with a BSN in the hospital improved the odds of a good outcome for all individuals and has a much greater effect on patients with Alzheimer's disease and related dementia. That having this amount of education was critical in care because they had the ability to do very fine assessments, act appropriately, much more than someone with less education, which is not an issue for you, but is a great issue for us. In Pittsburgh, where I live, approximately 46% have a BSN. That's it. So you are way in front of us in that area, and you really see it with the type of care. Linda Aiken, I'm sure some of you are familiar with her. She did some studies in Europe, and what she found was an increase in nurses' workload by one patient increased the likelihood of an inpatient dying within 30 days of admission by 7%. But every 10% increase in BSN-prepared nurses was associated with a decrease in this likelihood by 7%. And findings indicated that patients in hospitals in which 60% of the nurses had BSN degrees, caring for an average of 6 patients, would have almost 30% lower mortality than patients in hospitals in which only 30% of the nurses had a BSN degree, caring for an average of patients. So the BSN really matters, and I really commend you for having this as the level of education. Now, when we talk about quality and metrics, they are very, very important, and also is developing a culture of quality. So I wanted to talk a little bit about culture and just culture, because we can have the best strategies in the world, but if we don't have a culture to support them, they're going to fail. And one of the problems we've had in healthcare historically, I think in many countries, is we used to have the physician was the captain of the ship, and that does not work. We really need to remove hierarchies. And we need to rely on the expert in the room. The expert may be a physiotherapist, the expert may be a nurse, the expert may be the physician. But that is really, really important that we defer to expertise as we move forward. And Ken Blanchard is actually one of my quotes. I Google some quotes as well, Nora. And culture eats strategy for breakfast, and until a leader understands that, they're not going to be successful. So you really need to work on changing the culture, which can be slow and hard. Transformation is very hard. It requires vision, effective leadership, infrastructure. But I think in healthcare, if we focus on improving patient care and staff working conditions, that really helps change the culture. And as I say, you can't take your foot off the gas, because culture, it can take decades to build and mere moments to disappear when leadership is distracted and lose sight of its purpose. So we really always need to be staying focused on quality. Now, many of you know, anytime you read an article on quality that's historical, it talks about the beginning of the safety movement, that a tragedy that spurred it was in 1977 when two 747s crashed in the Canary Islands and it killed 583 people. And that's kind of where it all began. And I think it's important to reflect on that, when we don't have quality metrics, when we don't measure things, when we're not always attentive, terrible things can happen. And this quote is always seen lots of times with this as well. I added women, I am a feminist, but Admiral William Frederick Halsey, there are no great men or women, well maybe a few, just great challenges which ordinary men and women out of necessity are forced by circumstances to meet. And I think that is really important. And when I say ordinary men and women, I'm not just talking about nurses or physicians. In hospitals and healthcare agencies and outpatients where the culture of safety is prevalent and important, even the housekeeper understands the culture. And the housekeeper will call a safety alert if they see something that is not correct or a patient is unsafe. So it's teaching all people to appreciate safety. One of the other things as we move forward in this complex healthcare environment, medical knowledge and technology have expanded sufficiently to require interprofessional teams. As I said, there's no more captain of the ship. The captain will change depending on the patient's issue. And it's critically important that we understand that and that we have interprofessional education in our schools so that students learn to work with each other. It becomes commonplace. And the patient experience must be coherently linked with high-quality care and associated clinical behaviors and systems to achieve optimal outcomes. Lucian Leap, who is from Harvard, he's done a lot of work on safety. And one of the things that I think is important that he really speaks to make things in a complex environment, he says, we need to move from looking at errors as individual failures to realizing they are caused by system failures, which I'll talk about. We must remove the punitive environment to a just culture. Just culture means you're still going to punish people if they're reckless, and I'll talk about that, but when the mistake is not their fault, they're not punished. We have to move from secrecy to transparency, which my colleagues have addressed. And care must be changed from provider-centered or doctor-centered to patient-centered. And and accountability needs to be universal and reciprocal and not top-down. So that's important. And what we will see in a just culture, we all know people make errors, and errors lead to accidents, and accidents lead to death. And sometimes in the past, we blamed the person involved, typically the nurse, for the error, and sometimes it wasn't his or her fault. And we punished them and we thought, okay, problem solved, but that's not true. Many times the problem is a result of a system issue, and we need to change the system or we're going to continue to have the same problem. And I think when we think about a just culture broadly, we need to all be thinking of that a constant concern for the possibility of failure even in the most successful endeavors. And we need to have deference again to expertise regardless of rank or status. We need to have the ability to adapt when the unexpected occurs and be resilient. And this is something I think that's critically important, that we all learn to be adaptable. Nurses are pretty good at this. An ability to concentrate on a specific task while having the sense of the bigger picture, being sensitive to the operations as well, because that's critical to safety, and ability to alter and flatten hierarchy as it fits the situation. So they're very, very important as we think about a just culture. Today, as I said before, people were punished irrespective of the reason. And a just culture recognizes that individuals, practitioners, should not be held accountable for systems failings. And a just culture also recognizes many errors represent predictable interactions between human operators and the systems in which they work. So, some of the technology we have, like Massachusetts General Hospital created IV pump computers that will not let the nurse put a medication in if it's outside the normal range, so that you can't do it. And that kind of makes you rethink that, okay, I'm making an error here. So all those kinds of technologies are very, very important. At Duquesne, we just started the first ever in the country biomedical engineering and nursing program. It's 5 years. And we did that because we know the technocentric environment in terms of healthcare and where it's going. I don't even think we know where it's going. And we think it's important that there at least a cadre of nurses have the nursing background, but they really also have this technical engineering background, that maybe these are the individuals who can create devices and really look at how we structure and develop things so they're safer for patient care. But we want to recognize that everyone is going to make a mistake in healthcare. It happens. And we want to acknowledge that even competent professionals will develop unhealthy behavior, shortcuts, or routine rule violations. And we need to have a culture that really focuses on safety and doesn't let people do that and doesn't feel comfortable, and I'll talk about it. And we want to have zero tolerance for reckless behavior. And that means everyone. It means the CEO, it means the surgeon, it means the nurse, it means the housekeeper. When you're reckless, when you completely disregard rules because you think you are more important or the rules do not apply for you, there has to be discipline. And with students, I always say, that means when you're not prepared. You've made a conscious effort not to prepare, and that's reckless behavior. So we want to take the focus off errors, and we really want to place it on the quality of systems design and on the quality of behavioral choices. And that's going to be a culture that we really are going to create. And we want to learn from system risk and behavioral risk. One of the ways I think we learn from that is if there's a system in an institution, whether it's outpatient or inpatient, for a patient safety alert. If there's something unsafe and someone's uncomfortable, that they can call and experts can come in and address it and look at it and hopefully analyze it and learn from it so it doesn't happen again. So I wanted to talk a little about human error. There's a few of them, and then I'll talk about at-risk behavior and reckless behavior. Skill-based behavior of human error, we know there can be a memory lapse. Sometimes you can forget or just make an involuntary mistake. And that's usually from being distracted or tired or too quick, or maybe an excessive workload, or you're just a lack of focus. So that's one type of human error. There's also rule-based errors where you apply the wrong rule to a situation. And there's knowledge-based errors where you do not know an area and you have not looked it up, or you think you know it, or it's just a new situation. So that is important. So we've talked about human error, and human error we want to typically, in most cases, just analyze the situation and see how we can prevent it. At-risk behavior is behavior that increases risk, but it's not recognized by the healthcare provider and is mistakenly believed to be justified. So I'll give you an example. You work night shift in an acute care hospital, and there's been a big focus on sleep. Patients need to sleep. They're complaining in their surveys that they don't get any sleep, so that the nurse doesn't check the ID band of a patient giving a medication and makes an error. That would be considered an at-risk behavior because the nurse is getting competing signals. They're getting a signal to let the patient sleep. Other people are letting them sleep, but it's not okay. But for some reason, and that requires coaching and remediation and a cultural change. At the same point, reckless behavior is a behavioral choice to consciously disregard a substantial and unjustifiable risk. If you're on that same unit, but there's a culture where everybody checks the ID band all the time, It's really clear, it's very important, and everyone does it, but you think you're above that and you make a med error. Or you just don't check it even if you don't. That is a reckless behavior, and that requires discipline. So that is justifying those three. And I actually asked our director of adjunct faculty and clinical affairs, who manages all our clinical programs, to look at making these distinctions with our own students. Because sometimes we give a student a professional violation, for instance, and I don't think they really understand why they're getting it, or we look like we're just being punitive. And I think if we can even in school start with these three types of behaviors. Is it a human error due to systems? Is it an at-risk behavior or reckless behavior? That will help us. I think to drift is human. We all do it, even driving. My husband does it more than most people. And I think an example of this is when people start talking when they're preparing their medications. They're self-distracting, right? They're self-distracting, they're drifting. They feel comfortable enough doing it, but it's not okay and they need to be coached. But reckless is reckless. Someone who's impaired at work, some type of substance or bullying, that's reckless behavior. That needs to be punished. There needs to be disciplined, and that's not okay. And examples of reckless behavior in healthcare are disregarding clinical policies or safe practice, failing to report a safety concern, speaking or acting disrespectfully toward another person, engaging or tolerating abusive bullying behaviors, looking up or discussing private information about patients outside of your specified job responsibilities, working while impaired by any substance or condition that compromises one's ability to function safely, and reporting false positive information to a supervisor to gain favor. And we really need to have a culture where the organization is bigger than the person when there's reckless behavior and it is reported. We have a system in Pittsburgh where if the student goes into the electronic medical record and looks up a celebrity, for instance, like let's say a hockey player's wife had a baby and they look it up in the EMR, it gets flagged and we get called. And if they don't have that patient, then they receive a professional violation because they don't realize that we can track it. So that's very important. And there also needs to be organizational accountability. We want an organization where healthcare providers can say they made a mistake, because by people admitting they made a mistake, especially if it's a system error, then we can look at it really closely and see how can we fix this, right? And we also want, though, everyone to be held accountable for their behavioral choices. It cannot be just based on your rank. I was on a board at Princeton Hospital in New Jersey, and Princeton is like Dalkey here, you know, like where Sinead O'Connor and Bono live. That's what Princeton's like in the United States. Very wealthy people. And there was a couple incidences when I was there on the board where there was not an understanding of some issues. So one was if there was a disciplinary issue I can't get into because of confidentiality, but the nurses were punished differently than the physician in the same issue. And there was outrage, as you can imagine. Nurses called the newspapers, they called the state, you know, it was all done, and nobody could understand why they didn't come forward. I said, well, you don't have, they've committed the same crime, but you have different punishments. And you need to look at the system that clearly everyone is responsible for their behavioral choices, but the punishment, one shouldn't get a slap on the wrist and the other two get terminated. That's not okay. So I'm really looking at equality with those and having a distinct line between human error, at-risk behavior, and reckless behavior. And as I said before, coaching with the first two and discipline with the last one. Now, I think everyone does root cause analysis or looking at when we have errors. How will you investigate and learn from the events that are crucial? There's always more to the story with human error, typically. And just saying, you know, somebody made a mistake and letting it go, you really need to look deeper. One of the things that we've done in the United States, you know, we have the patient safety alerts, but having public members and people not from your organization on your quality and safety committee and your boards, because they're going to speak up. So when I sat on a board for Hahnemann Hospital in Philadelphia and Princeton. I don't work there. I don't get a paycheck from there. I get nothing from there. I'm very comfortable to say, not okay, this is the problem, nurses need this or that, where when you work there sometimes you're more timid. It's natural. So having an outside person would really be helpful with this regard. And this book is a little bit older, but I find it very interesting because it really talks about when to standardize care and why it's needed. And that a lot of the errors we have, quite frankly, are just from lack of directions. People don't have directions on how to do certain steps. So Dr. Bowmer asserts that essentially a process of applying best available medical knowledge to both research and clinical to solve patients' problems. And in recent decades, knowledge that underpins care has dramatically increased in volume and really sharpened in specificity, I can't even speak, enabling some treatments to become standardized while others are highly uncertain. But many are standardized and really looking at how to do that. And that is helpful in many reasons. Some nurses in the beginning were against it, but when you think about it, it helps a student. They know exactly how to do it. And if you're going to look at a problem, what went wrong, if everybody's following the same steps, you can look right away to see where the problem lies. I also have the Circle Plan, Do, Study Act or Plan, Do, Check Act, but I just wanted to talk about what's important with respect to this model. We need to educate everyone about quality improvement. And we want to empower healthcare providers to speak up when something's not right. If they see a certain physician never washing their hands or a certain nurse, it needs to be reported. We need to empower staff. We need to empower the consumer. We know that they can look everything up with technology, and we want to encourage that, but clarify when they have some misperceptions or misunderstandings because they're not in healthcare. Quality through transparency is critical, and you're moving in that direction, and that's terrific. I do think, though, we have to be careful with that as well. Sometimes Hospital A may have their safety metrics are not as good as Hospital B because Hospital A has very high acuity, right? And Hospital B does not. Or there's other reasons, or one group in public health, socioeconomic class is lower, they don't have as many resources, in terms of healthy food and types of living, and that's why there's differences. It's not necessarily the care per se. So we just really, it's one metric, it gives us an idea, but sometimes we really need to dig deeper to see what it is. We want to establish metrics. I have a slide later. Without standards, there can be no improvement. Very similar to what Nora said, but unless you know where you are, you can't get better. So that's really, really important. Culture, I can't speak enough of, and I think that when I look, I've been to several many hospitals, and I'm an acute care nurse, and I'm going to talk about one in a minute. Culture is the reason some are successful and some are not. That's it. And cost containment. We always hear we need more money, and I hear it all the time too as a dean, but lots of times we can be more efficient. And I'm going to give a story of Virginia Mason on what they did without really adding any money to really change an institution around. So I would say that central to Deming's philosophy that leadership is a key element to quality improvement because leaders set the culture with the staff, with the nurses, but they have the vision, they create the vision for quality and really start from there. And measurement and accountability for quality and cost are the foundations for healthcare improvement, and implementation and system redesign are essential for changing healthcare system and changing healthcare outcomes. So really, it starts at the top, but the people all through the organization need to buy into this shared vision for quality. It can't just be up here. Everyone needs to buy into it, but that needs to be the focus. So I wanted to talk about An example, Virginia Mason Institute. People know who that is? Some? And the Toyota production system, some people use a piece of it in some organizations. This place is all in. And I'll tell you why this place fascinates me. I actually read about it in Harvard Business Review many years ago, and their turnaround was so severe, I didn't even believe it. So they were losing money, they had a mediocre safety record, they were going to close, and I'm reading the article, and they're talking about how healthcare is a series of productions like cars, saying you admit a patient, you discharge a patient, you enter the community, and they're really comparing it to business, and I was really very, very skeptical. So I actually went there and spent a week there and did a lot of reading about it, and actually wound up putting it in my curriculum at another institution. So I just want to tell you a little bit about what they've done, because I think it's an exemplar for the United States. Not that it would work for everyone, but I think it's interesting. So in 2003, it's in Seattle, Washington, far away from where I live, the organization went on this journey, and they recognized the need for change. And what happened is the doctor, Gary Kaplan, who ran the hospital, sat next to a Boeing executive at Boeing airplanes, and learned how they really turned around Boeing by using a system for quality on how to have instructions for things and how to measure quality and safety. And through this, the hospital now has $15 million in revenue in terms of profit. It's #1 in Leapfrog for 10 years, the big safety award in the United States. It has very few lawsuits, probably one of the lowest in the country, and I'll talk about that because they have such a focus on quality that they don't have that to deal with like other hospitals, which is quite prevalent in the United States. And they're very, very transparent with errors. So I'll give you an example of one error. In the OR, chlorhexidrine and fentanyl were labeled the same, and someone gave chlorhexidrine instead of fentanyl to a patient, and the patient died, obviously. And they never, ever said who the person was who did it, ever, because they looked at it as a system error because they were labeled the same. And they actually have an award now named after the patient, the Mary Z. McClintock Safety Award, and they give it every year to the team who really works together and has great safety outcomes. So they took a negative experience and made it a positive experience. So they've also increased efficiency. They did not put new money into what they did, but they changed how they did things and wound up being much, much more efficient. And if you ever go there, it's not like my office. Every counter is clean. They can turn over an OR so quickly. It's amazing because they have a little ante room. It's all set up. They clean the room, move the next one over. Everything is built on being efficient in terms of the patient. And with this efficiency, they've increased safety, reduced cost, and really have done some really good things. So what's their philosophy? Their philosophy, they went from provider-centric to the patients first. They also went to waiting is bad. Now, I don't know about you, but when I go to a doctor's office, there's a lot of people waiting. I think, gee, he's a really good physician, but that's not okay in the Toyota production system. If you have a 9 o'clock appointment, you should get a 9 o'clock appointment. Defect-free medicine, meaning 0 errors. Rigorous accountability, always looking at being accountable. No new resources, so you're not throwing money at problems, you're looking at systems and fixing them. Real-time quality assurance, you can stop the line, stop something if there's a quality issue. Management on site. The management does a lot of walking rounds, they meet on the floor, everyone, even the CEO and the chief nurse once a week. And the other philosophy is we have no time. We have no time. allow this to go. We have to fix this safety issue right away. And they really look at it takes great people and great systems. So it's an embedded philosophy. It may not work for everyone, but I think it's interesting because it turned around an institution. This institution now gives, they make even more money. They have a foundation and they give classes. I brought a whole number of about 10 faculty from a grant up there to learn about Toyota for a week. So they really, and you can decide what works for you and what doesn't. But they say, first you're going to do no harm using the Hippocratic Oath and Florence Nightingale Pledge, and that mistakes are inevitable, but defects are mistakes that aren't fixed, and you do not want to have defects. And in most instances, mistakes are least harmful and easiest to fix when recognized at the time of occurrence. So they have a culture of safety. They have process to prevent errors, the safety alert system, standard working and training, lots of checklists and monitoring, good communication and cooperation and engagement and education. And they say they want 0 defects. And they looked at, and I said, 0, that's like kind of impossible. I'm kind of the skeptic in the room. And he's like, when you have 99.9% quality, he goes, think of it in the United States. 22,000 checks are put in the wrong bank account. You have 16,000 of U.S. mail are lost, 2,000 unsafe plane landings made every day, and 2 major plane accidents a week. So we need to have 0 and to really strive for that. But it is a philosophy, and one of the things I like about it is it's about long-term thinking, even at the expense of short-term financial goals. In the United States, we have a lot of for-profit hospitals. They have shareholders and boards, and they make money. And my bias is I have a problem with them because sometimes they make bad decisions to have a short-term financial gain, which is not good for the patient, so that needs to be looked at. And you want to build a culture where you're fixing problems right at the time that you recognize them. So it's quite interesting. The one thing, I talked about a lot of these. I will tell you a story about one of the things, is to use visual control so no problems are hidden, and some things that they did. So one of the things that they did, and again, this is about culture, they found they had a lot of med errors in the morning because the nurses were busy giving meds and the docs were writing all these orders, the physicians, at a really busy time. So they created a policy that physicians are not allowed to write medication orders for 2 hours during the time when nurses give meds in the morning, unless it's a super emergency. They also found with the decrease in lawsuits, they could have an extra nurse on the floor during that time to float. And they have medication rooms which have red bicycle lights on them and a place where the nurse stands and can prepare their medication in silence, that no one's allowed to walk in the room. I mean, they really adhere to a nurse not being distracted because they see medication administration as one of the real big safety issues, and a lot of it comes from distraction. So, and they clearly mark their anesthesia board. Everything is marked with what it is. I mean, some very good practices that really just take a little time to put in place, and they're done. And what I read in an article by Hall, that 89% of interruptions negatively impact patient safety. And you can imagine if everybody's asking you a question at the same time, you're really not focusing and thinking. So the other principle that I think is really good is that they tell leaders to go see for themselves to understand the situation. So they'll tell the CEO, don't stay in your office and look at a spreadsheet. Go down and look, because it means something very different. Make decisions slowly by consensus, but implement rapidly, and become a learning organization with relentless reflection and continuous improvement. So one of the examples that I saw when I was there is they didn't know how to do patient assignments, and we're always grappling with that, right? I mean, what's the best way? But what they found is when they did it based on acuity sometimes, the typical nurse had 5,818 steps in a day, versus if they put patients close together and gave them all within a certain range, you had 844 steps. So even though your patients might be more acute, you weren't walking as far. And when they assessed outcomes in their hospital, that was a better strategy. So here's my quote that I will take from Nora, but just in a different version. Without standards, there can be no improvement. And without working instructions, people don't know what to do. And without metrics, we don't know how we did. So it's critical. So I think going to the Gemba is the Japanese term, since they use the Toyota model. But go see for yourself when there's an error if you're a leader. Have an obsession with safety. I think we all need, as we said before, standardization of skills, language, and systems. We all need to be talking the same language. We want people that are engaged. We want transparency. And we do need to focus on money to a certain degree because we need to have a healthy bottom line. So we need to look at what do we waste? How can we be more efficient? And that's critical, I think, to moving forward. So one of the examples I wanted to give is Pittsburgh. It's a little bit of an old example, but our VA hospital used a Toyota production system. They were having an MRSA issue, and they decreased it 82% by using these principles. And they went from having 1.4 per 1,000 to 0.27. And they still use the Toyota production system now. The next thing I wanted to talk about with nursing excellence is Magnet, which is used in the United States. I will tell you right now, it's very expensive, so I think you can be Magnet without paying for Magnet. They say that in my research and talking to my colleagues, it cost about $500,000 to become a Magnet organization. It's like $6,000 for the application, and then depending on how a smaller hospital, $399, and less beds is like $35,000. Up to $68,000 if you're a larger hospital, so plus $1,850 a day for a visit. It's quite expensive. So I think it's a wonderful idea. I'm going to talk about it, but I would also say to you, you can be Magnet. People that are Magnet were Magnet the day before they got the designation, correct? So it started in the 1980s. And we found that 41 hospitals were able to have greater capacity to attract and retain nurses during a shortage. And we have a pretty bad shortage in Pittsburgh. So what does the culture of that hospital look like for hospitals, for those nurses to want to stay? And we found that nurses, where there's organizations for quality patient care, there's reward for nursing excellence in organizations. It's a very high honor. They also found that when nurses were engaged in practice councils, Magnet hospitals had 14% lower mortality and 12% lower failure to rescue. So nurses were engaged in the quality improvement metrics at all levels, which really helped with outcomes with respect to failure to rescue and mortality. I will say that only 6.8% of hospitals in America are Magnet. So it's a very small number, I think, because there's 49 standards. It's hard to achieve. It's also very costly. So sometimes only the more wealthier, affluent hospitals can afford to, or clinical sites can afford to have this. But it does create a culture that's very healthy for nurses. It really trains and encourages nurses to be involved in clinical research and improvement, and it's a more egalitarian approach for nurses at hospitals to be engaged in things. So I just want to give you a quick example. This is Children's Hospital of Pittsburgh. They've had Magnet twice. Some things that the nurse leader has done there. She has a shared leadership council strategy to enhance nurse engagement. She has a nursing administration fellowship where a nurse can be an administrative fellow to see if they want to be an administrator. Nursing bedside report to decrease serious harm. Parental involvement, parents in the OR until the child is put under anesthesia. Senior scheduling incentives if they have good NDN, QI, which are our patient outcomes surveys, and a professional practice model. And they've been awarded Magna twice. They also she created a system where a child died in the United States because no one would listen to the parent. So she created Condition H, where any parent can call the phone number and call a Condition H if she or he, the father or mother doesn't, or anyone in the family, doesn't feel someone's listening, then their child's really sick, and a group of independent physicians and nurses will come to that parent's aid, which has been replicated nationwide. So I just wanted to talk very briefly, because I'm almost out of time here, but why, one of the things I think that we need to do is put safety in nursing curricula so that we can all talk the same language. We are not perfect in the United States. 10% of all U.S. deaths are due to medical error. It's the third leading cause of death in the United States. Medical errors are under-recognized, and an expert, John Hopkins, physician in the next slide, says we have about 250,000 deaths per year. So we have a long way to go. Again, a lot of it is unwanted variation is endemic, and we need to have standardization and protocols with respect to that, and again, not punish people for systems actions. And a lot of things occur because of being afraid of legal action as well. We have a lot of lawsuits, a lot of lawyers or barristers in the country, so my niece just became one, so she'll be adding to it, I guess. But I wanted to talk about interprofessional education simulation. One of the things I think that we can help to have an egalitarian approach and change the culture moving forward is to fix it in the education system. And to fix it by having simulation where students work together, not maybe a lot, because it's really hard with scheduling and logistics, but even if they did it once or twice a year in the junior and senior year, it could be enough. And I call simulation the dress rehearsal. What it does is you're helping graduates capable of caring for patients in an increasingly complex environment. And you want to start having respect for interprofessional teams with senior executives. So you want to start at the top, but you also need to have people learning to work as a team together. Having interdisciplinary rounds and having no hierarchies with respect to patient safety. So I wanted to show you some pictures. This is a project I did when I was a Robert Wood Johnson Fellow. It was educating professional nurses and advanced practice nurses for tomorrow's complex clinical environments and emerging demographics, enhancing safety and interprofessional communication. And I purposely picked high acuity events that would have a high impact. Failure to rescue events, which we have there, both a neonate and adult with mannequins, and we have physicians, anesthesia nurses, advanced practice nurses, all work, sometimes other healthcare, psychology, et cetera, all working together as students with then a debriefing, so they learn each other's scope of practice, and they learned how to work in a team where it really made an impact for them. Here's another one. That's a birth simulator. That's not a real person giving a birth, but it's a bad delivery where the woman's going to hemorrhage after that. And in the control room, again, all working together with the debriefing afterwards, where they talk about what happens with that interprofessional education. And sometimes we purposely have people in there as actors that will act out and not act appropriately to see if the student will address the behavior. Here it's in the outpatient setting, giving bad news, not someone looking at the monitors. But it's very helpful. We teach closed loop communication. We did another one that I don't have a picture of that was very helpful. We have a problem with, I'm sure other people, with sometimes substance abuse with nurses, especially anesthesia and others. So we did one where we have an impaired nurse who's a senior nurse, and she is trying to bully a novice nurse to get narcotics out for her. And we actually broadcast it to the classroom, and we did one where the nurse succumbs to the nurse and just does it because she doesn't know how to manage it, and another one where the novice nurse manages it appropriately. Again, dealing with these really acute, high-impact events while in school So they're kind of prepared and they know how to deal with it when they graduate, because I really do believe teamwork can be learned. So in closing, I want to say that our emphasis must shift from an initial quick fix orientation to quality standards in a process, people-oriented focus for systems thinking and behavioral choices, embodying long-term thinking, efficient and effective systems, technology and added value, and teamwork within an environment committed to quality outcomes and continuous improvement. And we need to be certainly accountable for ourselves, but we also need to be accountable for each other, and that may mean sometimes reporting someone who is not acting appropriately. And in closing, I want to say when a flower doesn't bloom, you fix the environment in which it grows, not the flower. Thank you.